to improve clinical education, this should be communicated, or there should be a stakeholder meeting to have a second level discussion so we all agree that moving forward, it is what we are supposed to do. In fact, I am aware of this general form. And I wouldn't say that educators, we are lazy, but it is so difficult to do assessment form for each course, each module. I don't want to subscribe. My smiling is in different stages. It's difficult, okay? So at the end, how do we digitalize? Okay, so I'm going to go into that space. How do we use technology to improve our competency-based assessment? Let me go to Auntie Amma. What do you think we should do? You see, when I write paper like this for surgical nursing 1, another paper, surgical nursing 2, hey, how do we make it better?
Thank you, Prof. So we are saying that it is not easy for us to get assessment tools for each program or subject. For technology, wherever you are, you can utilize it. So as we talk about communication, effective communication between the schools and the clinical setting and our students, I think we can have a common platform where the clinicians on the field, the clinical nurse educators in the classroom will be on the same page, so that when the students are coming, we are aware that these are the assessment tools we are going to use for each of them, because it is difficult to come by the sheets and also having time to print all these things for them. Sometimes we even have some of the students who will come and will not come with the assessment tools. They come and tell you their forms have been posted by the schools. So you may be there and the 6 weeks or how many weeks is over. And you have to use the assessment sheet by the clinical nurse educators for that. But if we use technology and have a common platform where nurse educators, the clinicians will communicate one language, it will help in the assessment of these students. Thank you.
Thank you, Madam. Let me go to Kolebu NMTC. Auntie Vic, the audience will add on to assessment. You add on to the gap as to how we can bridge it apart from communication that is heavily here, dominated the suggestions. The professional values, attitudes. Somebody says the computer aid nurse, you can't find it. How do we ensure professional values and attitudes are maintained? In our rotation nurses, our nurse specialists, and our student nurses. I think the discussion is skewed to student nurses. Now you go to a facility and the nurse specialist is not wearing a nursing uniform anymore. Okay, I know it's fine. But the person is not even identifying herself or himself as a nurse. That's where my worry is. No matter how high I go, anytime I go anywhere, the first introduction is that I'm a nurse. But some of the professional linkage or connection to the nursing ethics, the nursing identity is getting lost. How do we bring it back?
Okay, I think if we talk about professionalism, ethics is one of the topics in the curriculum. I believe that in their updates, the NMC updates, it seems because we teach it during the first year, by the time the person gets to the third year, he may have forgotten. For me, I believe that it should be spread out throughout the 3 years of training. the values and the professionalism, the ethics in our profession should be something that should be trained from first year through third year. And it's my hope and prayer that as they go to the clinical site, the clinicians who are their models should also reflect on these values, try to practice it, because most of the time they talk about our behavior and our attitude. We teach most of these things in the classroom nicely, but when they get to the clinical side, it's another thing altogether. So if we do it continuously throughout the 3 years, and the clinicians also model what have been taught, I think it can go a very long way to help us improve upon it. Thank you.
So any addition from the table?
Yes,
Then in
I want
addition to the
Please
evaluation, the evaluation in this digital world, I think we have something we call the Google form. If we can develop it in a way and send it directly to the coordinator or to the clinicians, it will be better, because some of the students can write, they will do their own assessments and bring it to us. So if it is in a Google form, it goes directly to the clinician to assess the students, and then they send it back. That is what I also trust.
You want to add on? Yes, please.
Yes, Prof. What I want to add is that looking at our specialist nurses and midwives, I think the Office of Data Nursing and Midwifery and other stakeholders should come together and have a standard attire for them, because they wear their mufti and we don't have a prescribed uniform for them. Some of them have also become used to coming to the facility in any attire. When they've been asked even to put on the lab coats and the name tag to identify them as such, I don't know whether GCNM is here. When our products graduate from the college, some don't even want to avail themselves as nurses and midwives. And when it happens like that, it's very challenging, because they go to, some want to report to administrator the medical soup when the nurse manager is there, and the person places herself or himself above the deputy chief nursing officer, who may be the nurse manager. So when the nurse manager wants to meet them to even thrash out issues with them, some of them it's difficult for them to even listen to what the nurse manager is saying, let alone putting on a prescribed, even the name tag and the lab coats whilst at work. So our graduate from GCNM, the rector, Data Nurse and Midwifery's office, and other stakeholders should come out with a standard appearance for our specialist nurses and midwives, so that some of these issues will be curtailed. Thank you.
All right. So this one is beyond this panel. My panel is gap. Okay, bridging the gap. Okay. Uniform, we can talk about it later. Okay. As AOB, you wanted to add, please go ahead.
So in addition to teaching them in the schools, be it students or rotation nurses, nurse specialists, I believe that when they finish or when they come to the clinical area, we need to let them know from the onset our expectation, the performance expectation, the performance standards that we have in the clinical area. And also, apart from letting them know, we must monitor their activities, monitor what they are doing, and give feedback to the schools or whoever is responsible for them. I think if we do that from the onset, they know the do's and the don'ts in the clinical area, so they know how to comport themselves. But because I think now, because of their numbers, when they come and they go to the clinical area, we are more interested in maybe assigning them to the basic things that they need to do without looking at those areas. We need to go back and do the right thing. If not, I think where we are going, the gap will keep on widening. Thank you.
You want to add? Go ahead.
So, Prof, I want to look at it from the perspective of the Nursing and Midwifery Council having the professional code of conduct. As professionals, we are expected to comport and behave ourselves within a certain domain. Nonetheless, we expect senior colleagues that if the junior ranks are not putting on the best of behaviors, they can write to council. That is the most supreme way to address this thing. We realize that the nurse managers will complain, but they don't want to write. They don't want to be like or be seen as bad mothers, bad managers, bad senior colleagues. But if we don't set scapegoats or bring them to order, it will still continue. So I want to encourage all nurse managers. If our junior colleagues, the rotational nurse, the student nurses are not doing the right thing, kindly prompt council. We'll act accordingly. Thank you.
I like that. Please go ahead.
Yes, and with what you just said, I have done it before, and I got the answer from NMC. I actually wrote to NMC, and then it has changed a particular school with how they conduct themselves when they come to the hospital.
At a school?
Yes.
Okay.
Because I reported them to NMC and NMC acted. Now we've all seen the improvements from the students from that particular school. So yes, if you write to NMC, they will act. And then the rotation nurses, we are very intentional about their professional values at the hospital. So we have a well-structured orientation program we send them through, and we make them sign a code of conduct, and then they sign a social media policy. And then, and then there are repercussions when you misbehave or you communicate wrongly, disrespectfully to people, we act. And because of that, their conduct there is up to standard, I can say, about 99%. Hardly do you see any nurse or midwife from Ridge Hospital misbehaving on TikTok, or they don't do that because they know that there are repercussions and it will be upheld. So the orientation.
So can you share, if you have a platform, can you share a copy of the policy or whatever, so some of your colleagues can learn? That would be very good.
Yes.
Thank you.
Yes. And then their code of conduct, we have enumerated things that are not supposed to do in terms of absenteeism, lateness, insubordination, and you will sign it. Everybody signs it, and it's attached to your file. So you can't misbehave. And I think that's what other institutions should also emulate, so that we'll check their professional values and ethics. And then we, the clinicians, you know, the students and the rotation nurses, they are novice and intermediate. They look at what we do more than what it is said. So they emulate us, how we talk to the patient, how we talk to ourselves. When they see that, then you know that this you don't do that, this you can do. You don't talk to this person disrespectfully. When you are talking to your senior, you do this. They emulate what they see than what they hear. So we, the clinicians, should also do better when it comes to the students and the rotation nurses. Thank you.
Thank you. Now let me go to my audience. How many minutes do I have? Who is keeping the time for me? If not, I'll take all the time. How many minutes do I have left? Oh no, the whole thing is 1 hour. Maybe 20 minutes more. So where is the other microphone for the audience, please? Microphone, where is another one? They should come and speak here. Oh, okay. All right. So they have a stand microphone. If you have a contribution, a question, please approach a mic. One is here, one is at the other side. This afternoon we are looking at, I'm a nurse, okay? I'm a student nurse. How can I become competent? I need to pass as a nurse before I can do anything else. The foundation. Or I just qualified. I'm still not clear where I'm going. How do you help me get grounded in the profession? I just finished my 1-year rotation. I'm still not clear where I am. How do you help me become confident as a nurse? I've practiced for 3 years. I've gone into specialist education. Maybe I'm doing women's health. I've never inserted a speculum before. I've never done implants. I've never done anything that is there. There means, Auntie Amma said, the advanced procedures. But that is where my passion, my interest is. I just enrolled. How do you help me become that competent specialist nurse? We are not talking about uniform here now. Maybe when the director comes on stage, in the next panel, she may say something, but this discussion, the uniform issue is out. I just brought that in because it's something a lot of people have complained to me, and I'm not in that space with power to say anything. But because it's on my heart, it came out. So that's why I said it. So, sir, you have the floor. You can introduce yourself and then you can say what you want to say.
Yes, I'm Imoru Al-Hassan, coming from Northern Region. You have just got me because my first point was about the uniform. I wanted to suggest something on that, and that you have taken it out. I'm not happy because I don't know when we will talk about it again. But then, when we come to the training of the students, and then their clinical practice, there's one thing that I have observed. I don't know how widespread it is, and I don't know what we can do about it. Because many a times, I think the schools are supposed to have clinical coordinators and clinical mentors given an appointment to be able to function as such. But I don't know whether other facilities, they have given appointment to them. I have complained this several times, and it's something difficult for them to do. Is this something that must be done because it's a requirement that they must be given an appointment so that these nurses are chosen to be the mentors for the students or the coordinators for the students? This is something abnormal that I have observed that I think we should talk about it. And when it comes to the students' performance issues too, you realize that things have changed drastically in the sense that when people are trained, they are now made to wait for several years before they are given an appointment. And many of them lose their skills during that waiting period. I don't know what we can do to minimize it, but I think at first, as soon as people complete, they are given an appointment whilst they are waiting for their clearance to be given. That would have helped. But waiting for 3 years, 4 years, some people change different professions, hairstyles, or selling certain things, or become social influencers. Before one day they just tell them, portal is open, come and apply. And they come and join the system, and it becomes a problem to themselves and then to other clients. That is my contribution. Thank you.
Thank you. Please.
Okay, please.
The next person can come and stand. Go ahead.
Okay, please. I'm Eric Day from Uti. And then my first point is a suggestion that there should be immediate practical after clinicals or VT, that's vocational training. There should be an immediate practical session after clinicals or vocational training, in the sense that as soon as the students report back from where they have been assigned to go and do their practicals. You then assess them on what you went to learn. These are the objectives given to you. Okay, bed making. I should know this, do this, do this. Now come and do what you went to learn. So through that one, I think it will also help sharpen our nurses. And also, please, some staffs too. I wouldn't say all, please. Bear with me, please. Some staffs, I may say, because of the number that are given to them, they will say, oh, excuse me, because those same nurses are the nurses that will take care of you tomorrow. So what we do, what I'm suggesting is, we should ensure, say, we group them and then give them assignments. Make sure that you even if you don't get time, make sure that you ensure they do those assignments. Sometimes you can even encourage them that they will say their staff's strength is more than the patient. So I can't do anything. Let them use they themselves, the students. If it's bed making or changing of position on bed, let them, the students themselves, they should use themselves as practicals, not necessarily when someone is sick and the person is in. Thank you very much.
Sir.
Thank you, Prof, for the opportunity. My name is Lawrence Barwin, nurse manager, Laura Hospital.
Where?
Laura Hospital.
Okay.
I want to share a practice that is helping me as a manager in Laura Hospital, because I have a training school by the hospital. In terms of managing the numbers, we work with the school, especially the intra-semester practicals, such that they schedule the people in turns. So they have 5 classes, and we have 5 days within the working weeks. So they allow 1 class each to come on specific days. Now, that is helping me as a manager to the extent that I have few hands to be able to manage. And I have people helping me throughout the week. The proposal I want to make in terms of managing numbers to the rest of the facilities, can we look at this strategy and see how we can deploy, especially the experience during break, such that we deploy them in badges instead of pushing all of them at a go. That is where the numbers get money and we are not able to manage them conveniently. Now, I also want to support the point that CNO, I think Ashanti made about the rotational nurses. Prof, if you ask my opinion, I think the major problem with the rotation is compromise. The reason is that almost every batch do rotation on empty stomach. So they come, you see that there is something right to do, but you are also forced to compromise because they are hungry. They do the rotation on empty stomach. They will now finish and they will now pay them to go home and spend. So I don't know whether it is beyond the recommendation of this panel to insist that if there is no clearance for the people to do rotation because it's attached to the national service, then they shouldn't start. If not, we are forced to compromise many of the instances to let them go through. Thank you very much.
Thank you. Yes, sir.
Thank you so much, Prof. Mine is also...
but how come I have only males? Hey, assembly. Okay, so after the male, then the female will now go the next batch, okay?
All right. My name is Seth Mijida.
Okay.
Nurse manager at Kintampo Municipal Hospital.
Kintampo?
Yes.
Okay. Kintampo Regional Hospital.
All right. It's on the process.
All right, please go ahead.
All right. I want to find out whether the nurse specialists and the midwifery specialists, they are still under nursing administration. And if yes, I will plead if this panel can also send recommendation to the right authority so that they will do proper orientation, because some of them say they are not working under nursing administration. Thank you.
All right, the last person for this badge. Then we'll go to the second. Yes, we'll go to the second badge. Please go ahead.
Prof. My name is Jefferson Asari Dampa.
Please, less noise. Go ahead.
I am not a nurse manager yet, but I want to make some emphasis and also ask a question. I understand that standardization improves practice. If we have standards, it improves practice, and also training will induce ethics. My question is, the institution mandated to ensure that we have standardized nursing practice and well-trained nursing students are only seen organizing examination. And mostly when you talk about it, they mostly say, especially NMC will tell you that, write to them. I want to understand, do they have monitoring and evaluation team as part of their structures? And what are their functions? They should educate us. What are the things they do to ensure that the practice and the ethics, standards of practice are well maintained? Thank you.
Thank you very much. So we'll come around again the next round. So I want to go to my panelists. Some of the questions, oh no, I'll come again, yes. Some of the questions I can answer, but I'm not a panelist, I'm a moderator. So let me go to my panelists. I'll start from the bottom. It's easy to answer. NMC. When it comes to standards, we don't see you. Exams, we see you. Tell us what you do.
Okay, thank you, Prof. Council organized a lot of workshops for nurses. We have a website open to training of nurses all year through. We have the WCEA where informations are uploaded there for nurses to read, and then have some form of exams to test their knowledge on what is being read. So he mentioning the monitoring and evaluation unit is in full force at NMC, ensuring and enrolling programs all year round. Just that, let me add this, most of them are not free. Yes, we merge with most institutions, and such workshops are being organized year round.
So the question is not on workshop. We want to see you visiting us to monitor standards of practice. So tell your registrar that is not about training alone.
Okay.
We want to see you on the field.
We do go on monthly visits. Yes, we go for supportive supervision. This year, I have been to St. Gregory. I have been to more than 10 facilities this year on support supervision. Have I visited any facility this year? If a nurse manager is here, you can lift your hand for me. Anyway, I'm in the central region, so I do visit facilities and health training institutions within my region.
All right, so
we do go for...
The feedback is that we want more.
Okay. Well noted.
Right.
We'll do more. Thank you very much.
Thank you. This CNM is not here, so I don't want to go there. Another next year, I'm praying that 80% Ghana Health Service, 10% educators, regulator, all the people who matter to achieve that document that we launched this morning. If the other people are not on board, you cannot achieve it all. So please, try, Auntie Eva and your team. Let us all be present whilst we discuss. So this year, unless somebody here is confident to respond to the fact that the nurse specialists are not working well with the nurse managers. Is any of you confident to say something? Auntie Amma, you want to say something? Is it working?
Yes, please.
Okay.
I think I said something like that. That some of them.
No, we want the solution.
The solution. The solution is that what some of us have started doing is that when they come back, when they graduate from the college, we meet them as nurse midwife specialists, and in that meeting we discuss their roles and responsibilities as nurse midwife specialists and where they will be posted to. Because when they graduate from the college, they come to me, and if where they were working does not suit that person, we do the reposting and send the person to a facility where he or she can function. So we do that, and before you go there, you are made aware that you are still a nurse or a midwife. So as you are going to work with the nursing and midwifery administration and the team there. Whatever reports you churn out, you'll be channeled through the nurse manager or the block in charge you work with. So they are aware. So this is what we have started. But it needs a lot to do. Yeah. You can't just have it easy. But if you engage them, they understand and they are willing to do their nursing and midwifery specialty. Thank you.
Okay, so because I was part of the college at its inception, I was the foundation faculty chair for oncology nursing. My comment is that the specialist cadre, you know, when you compare to the medical program, they have the membership, the fellowship, etc., etc. Our nursing and midwifery specializations are supposed to have that identity that set them apart. The fact that we are setting them apart to, you know, lift the image of nursing and midwifery doesn't mean that they should disconnect from the nursing and midwifery profession. And it also doesn't mean that we should force them to do bed making and do wound dressing if their specialization is not in that space. I would encourage all of us to give them the room to shine. When they shine, the credits come to you, the nurse manager or the facility. Okay? But like I said, I'm not currently with the college and I can't say much. But all that I know is that there's that gap in friction between this newly, she thinks she's a member specialist, and I'm also there before you came, kind of. Some of the facilities Nkoye, and I want to plead that you help them, like she said, repost them, give them the room to practice what they were taught. That said, the other thing is a delay in the financial clearance or employment. So that makes the issue about the rotation nurse or the newly appointed nurse very, very serious. Because when I was in school, I didn't get a chance to practice very well. The rotation to were many. It's like the brother said, and then the person was not appointed or employed immediately. But even if you are 2-3 years, they were few. So when a person comes in after they have been given the financial clearance, it's like tabula rasa. So the issue that we are discussing is more complex than normal. And I'm thankful to our brother who brought that aspect up. So they gave me 10 minutes more, and I want to give 2 women the chance to do their contributions, and then I'll give the concluding, and then they can answer the few other questions that I have here. So the floor is yours, Madam.
Prof. Yeah. Thank you so much, Prof. I think earlier submission, you talked about leveraging on technology and I think it is long overdue. Our regulators, especially when it comes to press service, I want to cite two major issues that occurred in my region. Absenteeism, Greater Accra Regional Hospital just said it. The rotation nurses are assessing themselves. NMC screenshots logbook, that page. And they know my signature. They know my stamp. And they know that NMC, Greater Accra, if I'm not there, I've given them official notice. If in my absence, this person is supposed to sign. So they know our signature entries. But this lady assessed herself, endorsed, signed, and unfortunately wrote Vivian upon Jera. I don't use upon, I'm Jera. And the stamp that we use is purple mauve. This person used black stamp. Yes. So quickly, NMC screenshot it, sent it to me, my nurses, and said, no, this is not chief's lesson, so we should look at it. And indeed, it's true. It wasn't from us. Another lady, a pregnant lady, came to the office with their father. And this one to one of our facilities, and I know the nurse manager's name. So when we asked this lady, somebody who has done her rotation in Greater Accra, at the end, went to Central Region for the nurse manager to sign her logbook. So I had to call the CNMO Central Region. That this person didn't do her rotation in any of your facilities. How come? And this person, it wasn't the CNMO, but it was a nurse manager at one of the bigger facilities in Central Region. So I asked, in your absence, who signs? And he said, oh, because of the nature of their terrain, nurse managers around do sign. So I think when we leverage and talk on technology, it is going to help a lot. When you are done, straight away, the nurse, that's the facility in-service training coordinator, as well as the nurse manager, will sign, and it gets to the region. The region, wherever you are, you just get the information on each student or rotation nurse. So I think it's important we look at it, which will help. Because the way things are going, it is not the best. I can cite so many examples, but I think just these two will help us. Thank you.
Thank you. Yes, ma'am.
Hello, my name is Josephina Bibio. I'm from UK, the chair for Ghana Nurses Association. I just wanted to contribute towards the nurse education and the mentorship and the nurse education. The nurses, hearing what the student nurses are going through to the world and coming out without getting the experience required because of the numbers and all that. And I was wondering, are there specific mentors in or preceptors in the world? Because if they are preceptors or mentors, they know their responsibility is that when they get the numbers, they see through that the students get well before, go through their objectives before the end of their practice placement. And also sometimes the nurses on the wards, do they get the chance to do some CPDs? Because some of them, if they haven't done CPDs, they don't feel like teaching anyone because they are not up to date. Other contribution too is the conflict between the specialist nurses and the ward managers. I mean, there are a lot of specialist nurses in UK. They are advanced nurses or nurse practitioners, we call them. And the ward managers or the, we've got two types of matrons. We've got modern matrons and community matrons. The community matrons are case managers or specialist nurses. So the ward manager, you do your administration and ward, and then the case managers or the specialist nurses, they are disease managers, and most of their mentors are the doctors. So I don't think there should be the conflict. It's because probably we haven't got to know much about it as a whole nursing body, so that we must keep on raising the awareness to ensure that the specialist nurse coming with a master's in the disease management is going to enhance the care of somebody with long-term condition in the community, whereas the ward manager, you are doing your administrative work. So let's, try and work together with these areas. And also, the specialist nurses must have a JD so that they don't come from the university thinking they've done their masters, and so they don't have to conform to the rules of the profession.
Thank you very much, ma'am. So I'm going to my panelists, their final words. Their final words, you want to make a contribution, please go ahead.
Thank you very much, Prof. I think two things have come up, clinical education and dive deep into the specialist training. I would like to split the two. I would have loved to have a whole discussion on specialist nurses. But unfortunately, I think we didn't get the college to do, we didn't do the collaboration very well, so probably that will be one of the lapses. And we have to look forward to having a conversation about specialization. You see, specialization in nursing and midwifery is our future. The current state should not be the reason why we would take some reactionary measures to say, do this to them, do that to them. We have to be very careful on how we work out the nurse specialist or the midwife specialist in the health system. I don't want to belabor the point on that, but let me come to clinical education. We have a clinical education where the one who teaches does not practice, and the one who practices does not necessarily teach. So if you have a system like that where these two can't meet at one point to have a discussion on the way forward, then we are going to have a clinical education system which is very disjointed. It is a system we must create. It's not, I could hear a lot of complaints about how it has been and the solutions that have been put in place. These are, the complaints that came are issues about, I call them branches. You see, when you see a tree that is dying, it starts with the leaves. And you'll be tempted to go and address something in the leaves or the branch. But there is something going on down at the root that we need to tackle. And so for clinical education, there must be a great conversation about it. Because you have 51% of pre-service being clinical education. 70% of the specialist training is clinical education. And then 100% of rotation is clinical education. There must be a greater conversation about it. And one that starts from the nurse manager of the facility having a conversation with regulation and training, so that when students are coming, they are not coming with objectives that people cannot even understand what they are looking for. Because the objectives that are coming are different. So first year alone, the objectives a school will send to this side is different from another. And sometimes the objectives, to be very honest, Prof, they don't make sense. So we need to have a greater conversation so that it is not objectives coming from a school, but a school having a conversation with clinical practice that is telling you, I'm bringing my first year students. We know by first year they should have learned A, B, C, D, or A, B, C, and D. So that when they are coming, we know these are the competencies that go with it. So I'm loving the conversations, but let's go down to how do we develop that system? Because we sat in clinical practice and in-service training, which was the one taking care of pre-service, suddenly became an HR duty. So ask a lot of nurse managers here. In-service is now looking like HR. So there are issues going on that HR is picking up in-service. We are not sure what we are doing. And that is why now there's a guideline looking at clinical education, because for us, the domains are 4. It goes beyond in-service. But so if the domains are 4, how do we create a system within a nurse manager's office where she's looking at clinical education within those 4 domains? what are the discussions when it comes to pre-service? She's looking for preceptors, she's looking for mentors. And these mentors and preceptors should be based on technical areas. So if it is surgery, we know the preceptors in the facility that are surgery specific, those who are medicine specific, those who are, the rest can teach. But teaching is not everybody's skill. So if they come and the preceptor is not available, whoever is there can be supportive. But the preceptor must be intentional in teaching these students. Thank you.
The chief has spoken. Fellow members, I believe that Rome was not built in a day. We should journey one step at a time. The discussion, we understand there's a problem. We understand the areas, students, rotation, those who just are employed, and then the specialists. My suggestion would be that this forum is too huge to have a first draft of such a discussion. The chunk of it will come from NMC to say, for every first year nurse, these are the skill sets. So I don't need to bring objectives. Once I am in first year, first semester, these are the areas. I'm in first and second semester, these are the areas, second, third. Then, if you just finished, you are rotating. What are the areas? We go to mental health, we go to ONG, we go here. What are the skill sets in these areas? Now, saying this is not the end of it. I'm envisioning a system where every facility will have a skills training room. So before I go to the human being, that rotation that stayed at home for 3-4 years should do something simulation before the human. But these are all capital intensive. My panelists, the issues that are left for you to do your last comment on, last comment plus any of the things you want to say relating to. One, somebody asked whether the clinical coordinators or mentors should be given an appointment letter. We have not answered that question. The delay in employment, that one, somebody has said something about it already. Then there's also the nurse manager who said that he thinks that the students should come in badges. That is if there's only one school, one controller. Remember, in the tertiary institutions, the nursing is just a program in the whole university. So if you want to do piecemeal, which timetable are they going to use for you? That is another complex discussion. But if it is an NTC, it is possible. So these are some of the areas that we have not commented on. So let me start from Antiama. When we get here, then we are done, please. Your last comment, and if you want to say anything else.
Thank you. My last comment is that I want to appreciate our clinical educators, the nurse educators, clinicians, on their vital role they play in training our students and also during rotation. They are doing so well. And I want to add that we should all strengthen our collaboration as health facilities and the training institutions, and also strengthen clinical supervision. Thank you.
Okay, so I want to talk about the preceptorship she asked. Yes, and we have preceptors. However, they have not all received formal training. And then it's not structured. So people use their own initiative to teach the students and the rotation nurses that comes in. And that's one thing we should also look at as a service where we have to train the preceptors and have the same knowledge across board, whether public or private. Then we have a standard training for our students and rotation nurses. And I also want to say that, yes, we are shaping the future of nursing and midwifery in Ghana. So when we guide, we correct, and then we mentor these rotation nurses and students, we are also shaping the future of the healthcare that they render to the service. We shouldn't see it as a burden or an additional, maybe a burden, but then we should see it as a responsibility, a role that in the end will be better for the profession as a whole. And then also we should look at giving the preceptors incentives so that it will motivate them to do more for these rotation nurses and students. Yes, that's what I have to say.
Okay, I want also to talk about preceptorship. I think I agree with her that there should be more training. Actually, in Kolebu NMTC, last year we called all the preceptors and to have a meeting, and we wanted to train them, but it involves a lot of funds. So after our first meeting, we went out soliciting for funds, but we have not yet received it to train some of the preceptors so that they can help our students. Then somebody was also talking about clinical coordinators. The schools, what we've realized is when clinicians are posted to the school, they are posted there as tutors. But we wanted clinical coordinators who will be in the skills lab, and they will not be in the classroom, so that they can assist with the training of the students at the skills lab. But unfortunately, most of them come and they want to go to the classroom. So this time we are requesting that when the ministry posts them to us, they should be specific that they are going to be clinical coordinators, and I think that will go a long way to help us with the training of the students as they together with the tutors. And I think there should be that collaboration also between the clinical side and then the school. We should have that kind of coordination, just as we were doing previously. I remember we were doing, Jipaigo was training the midwives, and they have this thing they call the learning guide. So one for the tutor, one for the preceptor, one for the students. And that is what guides the preceptor in their training. And we were working together. We try to meet every year to discuss things about the training of the students. We also try to motivate them, as she talked about it. The preceptors should be motivated. Nobody wants to work free without any motivation. And I think if they are preceptors, if we have a way of even using their preceptorship as CPD points for them, it will also go, it's a way of motivation, and it will go a long way to help them. Thank you.
Right. I finally want to conclude on the fact that there is a regional office in every region. NMC has a regional office, and I want to encourage all nurse managers to engage the regional offices, especially in their clinical meetings. If there is the need for any capacity building, any topic that needs to be dealt in relation to professionalism, ethics, any form of building capacity among your staff, you can officially write to any of the NMC offices within your region, and I'm sure the officers will be in to support. All this is geared towards improving supervision, improving standards, and ensuring that medical legal issues around this time is lowered. So kindly knock on our doors anytime you need us. We will gladly serve you. Thank you very much.
Thank you. Yes, I would say that in addition to whatever has already been said, and training of the preceptors, I would say that let's structure mentorship. so that the students will have the students will have their preceptors known to the schools. And in doing that, it means that I'm also encouraging that there can be letters, appointment letters given. And if letters are given, it means that assignment has been given to the preceptors. And the students are many. And therefore, I will also advocate for motivation for all preceptors, so that whatever they are doing will also be under monitoring. Thank you.
Thank you very much, my distinguished panelists. This conference is about the role of the nurse or midwife manager. We have discussed issues relating to clinical education. From the discussions thus far, what are the roles of the nurse and midwife manager that we are going to go home with? The first one is that we need to come together to plan. Planning is a managerial function. My hospital in Senya Breku maybe receives students from school A, B, C, D. What prevents me as a nurse manager to organize a Zoom meeting, for instance? We said we should use technology. They don't need to drive all the way. They don't need to. You don't need to have a budget for lunch for that meeting. To cut down the budget is a Zoom meeting or a Teams or Google Meet. Use any of the platform you are comfortable with. To say, when we came to the nursing and midwifery senior management conference, this issue came up. How can you plan the placement? How can you help us to avoid the large number of students on the ward at a go? We can start from there. The other one is, can you help us to, second meeting, have a presentation on what are the key clinical competencies of the first year, the second year, or the third year students? When you are doing this at your facilities, when that meeting is called by the center to develop the structure of clinical education from the Ghana Health Service, you are a step ahead. The other one I picked is how we, as a facility, can have a document, a pager, half page, whatever, that has our logo, the logo of the Ghana Health Service, as a commitment form that our newly employed nurses, rotation nurses, or anybody who comes there for a period of time can commit to by signing. I said on a board, even though we saw an oath at the minister's office, the particular board that I'm serving on, we saw another oath to commit to that particular institution. I was surprised. It was the first time ever. I said, how can you swear oath twice? But the words were a little different. Committing to regular meetings, committing to A, B, C. So at the end, you said that you would do it, and you have sworn the oath, and you signed. So anytime that particular institution calls for a meeting, I remember that I swore that I'll go for regular meetings. Then I asked for a hybrid, that I join online if I'm not able to be physically present. So there's that mandate or responsibility or role for you as you go back to see how you can enforce professionalism, ethics. NMC says report. How can you, some people, it's not as if they don't want to write, they don't have the confidence. They are afraid. They are not, their leadership is not structured, so they think that people will talk about them. If you are a leader like that, you don't belong here. You don't belong here. The people will talk. There's noise. Just focus on what you are doing and go ahead and do your work. So you need to, you the manager here, I know that you are not part of that group. So your other colleagues, you need to empower them to learn how to write succinctly. What is the problem? What did the person do wrong? Full stop. Don't add any salt or pepper to it. The other one I picked from the discussion is the conflict resolution. Auntie Oponi said that it's not easy, but she's been able to discuss with them. You know, some of the young ones, we didn't mentor them well at the student level. They finished with some shoulder. They came in rotation, we didn't mentor them. The 3 years that they worked, nobody mentored them. Now they finish specialization, they think they are like this. My daughter is back from SS school, they are on midterms. So first term, I asked her how she's managing with her colleagues. Then she said that there's a girl in the class who is very arrogant or something like that. And so my class rep, the class monitor was talking, and she was also talking, and she asked the girl to keep quiet, and the girl was angry with her, and so because of that, she's not talking to her. Then in the evening when I was chatting with her brother, I said, yes, Clash of the Titans. So I was what I'm just trying to say is that this current age, if we don't try to meander around them, we cannot handle them. So I asked her, so how do the teachers see you? If your friends think that you are bossy or you are, oh, the teachers are okay with me. In my mind, second year, third year, you come and tell me a different story. All that I'm trying to say is that the children these days, we need to help them to calm down. The fact that I'm VC, I'm standing here, I don't feed you, I don't clothe you, so I don't have any power to lord it over you, okay? We are all here together. Tomorrow, we will not be here. Life is very short. Look at what happened recently to our nation. Very tragic, okay? So these people, mind specialists, meander them. The current generation is different. And if you are also here as a nurse manager, and you are too stiff, relax. Some of you are too chinchini. Go hokakra. We are chinchini do abba. We are chinchini said you want to. So conflict resolution is one of the things I'm taking away. That for us to help the students, the rotation nurses, the newly appointed, the specialists, please, we need to learn how to resolve conflicts. The last one here is the one that I didn't hear from any of us. Stakeholder engagement to make this happen. It's not going to be easy if you want to do clinical education because you see, in the curriculum is a practical that NMC would assess at the end of the training. There's nothing to assess hospital-based. So the question is, who owns that clinical training? And how do we make it such that I'm supposed to do it and I'll do it? Because legally, I'm a student of school A, and this is their curriculum. So if you bring any clinical education something, and because of that, I can take you to court and I'll win. Because I don't have any legal relationship with you. We need to look at that critically and see how we can partner. So the stakeholder engagement in this process is very, very, very important. Now, nobody also spoke about the financial implications. My sister said that we need clinical coordinators. I started my career as a nurse technician. Those of you who were in Lagos those days, 2001, 3, 4, going 5, 6. I was a clinical, a nurse technician is like a clinical coordinator, kind of. If they had insisted that I should stay there as a clinical coordinator and not move on to whatever I wanted to do, where would I have been today? We can't box people in there and not give them career progression. I do not believe in that. I believe that I can come in, do it for a number of years, and move, another person comes in like that. But don't make any attempts to force them to be clinical coordinators for senior clinical coordinator. It will be some way. The current generation, they won't stay, okay? If the person is already retired, so at Legon, we brought in the retirees who were in the skills lab, we were all working together. And then the one that I also didn't hear is that the students that we have are of different categories. When Director Eva showed the graph, she said that the enrolled nurses or the clinical preventive clinical, from say, nap. I didn't hear anything, the dynamics between the nap who is not on study leave and is doing sandwich or weekend and our passing year. Now upgrading them have become, there are a whole lot of issues. All that I'm trying to say is that as nurse managers, when you come to the table, when you are called to help to design, think through the things I've said. You cannot force me to do something if I don't have a legal, I won't do it. Okay, if I don't do it, you can't do anything. If I go to court, I'll win. Remember that. Everything that we are doing, there's financial implications. Where do we get the money from to roll it out? If you want to do clinical education, it goes with skills lab, simulation. For all the Ghana Health Service facilities that the students will go to, the rotation nurses will go to, there must be the skills training lab before you go into the human interface. And lastly, I want to say that my panelists have been very, very excellent. This afternoon we heard from Miss Ida Dugan. Give us a wave and let's give her a clap. We heard from Mrs. Victoria Boateng. We also heard from Dede Adamte. We also heard from Auntie Amma and Shua Opuni. And we heard from Auntie Eme. Where is your name? Your name is hidden, sir. Eme Akote. Oh, I've left you, Okay, I think I've left you one name. Huh? The NMC one. Me who be NMC. I don't know. Oh, okay. So I want to thank them very much for your time, and God bless us all. Thank you.
Very rich discussion taking place out here. Can we be absent for a second? We've been sitting for too long. Just for 1 second, please. Just rise for 1 second, stretch ourselves, and then we sit back. Just stretch yourself a little bit. Okay, we can take back our seats. Thanks so much. I actually wanted to add my voice, but because I'm coming up here, I decided to keep that until now. I thoroughly enjoyed the discussion and the richness of it. Also because I am still in the classroom, I'm still a teacher. So I'm the closest to you in terms of talking about the theory practice gap. And this is the best forum for that. And I hope and I wish it's going to be a frequent discussion for us to engage on some of these issues. But personally, in terms of training of nurses, as a teacher in the classroom, and you as managers and leaders in your facility, if you ask me, I think you are the most important than those of us in the classroom. I agree, we are part of modeling the students. But what makes the student a nurse, about 80% of it is dependent on what happens in the clinical practice. Nursing is a practice-based profession, isn't it? And of course, Prof mentioned, we are not denying the fact that it is very challenging managing the large number of students that come to a facility. And of course, there are heterogeneous group of students. We're having the NTCs, now we have the university students coming as well. And I agree again that yes, we need to know the competency levels of each of these categories of students, whether they are first years, second years, or third years. And similar to what they come in as objectives. And of course, we do get some of the report about the inconsistencies and the ambiguity of some of the objectives that send you. And this morning we talk about innovation. So the challenge is on all of us. How do we become very creative? How do we innovate to manage these chunks for large numbers of students that come to facility, for them to benefit and for them to train to take care of you and your family and the nation at large? Much of it is down to us. So we are talking about ethics and professionalism. It is grounded in clinical practice. And it is only you who can train and model the student or that nurse or rotation nurse to be what it takes to practice as a nurse. Without you, nothing can happen. We can do all that we can do in the classroom, but when they're in the clinical practice, we see so many inconsistencies, so many information. Like what you mentioned, we don't know where their logbooks, you send them with our friends, their families, and all that. We don't get that. But we are hoping to have a clinical environment that we can trust, that when the students are out there, we are absolutely sure that they are getting the best, and we are giving them the feedback that can fit into the training of that student. How do we know? I do agree we need to improve the communication. I do agree we need to have some training in terms of CPDs for preceptors. And the preceptor to me here, all of you and everyone in the clinical environment is a preceptor, depending on the level of the students we have. The exams they write at the end of the day mean nothing in terms of training the students. It's all about how you model them. So if we have the same agenda, have the same idea, and know that we are training these people for the nation, we can all come together and find solutions. Besides, we are leaving the nation at risk of the people we are training. So the challenge is all of us. Let's find creative way of engaging. How do we manage these numbers? You may say you need to appoint a clinical education practitioners, and I mentioned there are cost implications. In fact, bridging that theory practice gap. Simulation centers, how many, and how equip our clinical skill lab so a student can go through there. When they come out there, they can function and function appropriately. NMC have revalidation coming up. We cannot teach ethics throughout the 4 years if you're in a university. The base rule of it is in the clinical practice. But if we don't trust and we don't communicate, we don't engage effectively, then students take advantage of the loopholes, and therefore they cannot be found, and that affects their training. And of course, you heard of the novice to expert practice, Patricia Berma. You don't expect them to become proficient overnight. They need to be supported. they need to be engaged. And I agree, the posting takes long. Quite often you find most of them working in chop bars. What we don't do well is that we don't volunteer. But if you are a serious nurse and you want to be a nurse, after schooling, even 2 hours a week in a health-related facility should be able to keep and maintain your competencies. But that doesn't happen in Ghana. Elsewhere, I wasn't trained in Ghana, I have no classmates. But my experience is that the licensure right means nothing to me. It is you, when they come to the final years, you assess their competencies and their readiness to practice as level 1 nurses. Elsewhere, when we don't do the licensure, but we have a clinical environment that is trusted, that ensure that the individual meet what it needs to be able to perform. So that communication between the clinical environment and the training facilities, the universities and NMC are crucially important. But if we undermine that, then there's a danger ahead of us, which worryingly we all need to take note of that. I was more concerned about hearing that the specialist nurses do not want to be identified as nurses. That's quite unfortunate. And personally, I don't think if you become a specialist, you should not go down and do basic nursing. It is too early, far too early, for us to be having these issues among them. Because whatever they do in the field, their concern and their focus is about delivering and justifying what they're created to do. And that will go a long way to create that autonomy for nurses, increase and heighten, of course, how will I put it, enhance our image. So if the credit is not going to nurses, that's quite unfortunate. So I want to plead with them, there's a focus on delivering, never mind at whatever level. Let them distinguish themselves and give the credit to nurses. And that's the only way we can survive, the only way we can make case against other professions. But if they go back and come and they don't identify themselves as nurses, then I'm very much worried. Elsewhere, you won't even know that it's about how your practice that differentiates who you are, not about going to school, and not about giving the title. Whether you're wearing the same uniform or not, it's about practice, delivering. That matters most. So we need to take note of that. Thanks so much for my run. But the last, but not the least, we have all that we said this morning, and following the last panel discussion, the input and the output. After all the issues we discussed, we produce a nurse who's out there, whether adequately prepared or have baked. They are attracting the attention wherever they find themselves, whether good or bad. So this afternoon panel discussion, we have the title, Quality of Nursing and Midwifery Practice in Ghana. How do we change the narrative as managers? Good narrative or bad narrative? So in the next few minutes, we shall see how the discussion goes. And to help me do that, I will invite the boss herself, Director of Nursing and Midwifery Services, Ghana Health Service, Madame Eva Bensa. There can't be anybody more important to do justice to that than her. With her, we also have the Director of Nursing and Midwifery Services, UGMC. The Director of Nursing and Midwifery Services, Kolegu Teaching Hospital. I'm sorry for you, this is the second time, sorry. So I'm privileged to have 3 big guns. Only 3, fortunately. I think they're tired, so we have only 3 of you, and I'm very much sure that you can do justice to all the questions. Ladies and gentlemen, to go straight to what I have here with my panel, and and to set the ball rolling. The quality of nursing and midwifery practice in Ghana, how do we change the narrative as managers? Madam Eva, I think I won't hesitate to come to you first as a big lady on the table. Setting the context, how will you describe the current state of nursing and midwifery practice in Ghana in terms of quality and outcomes?
Thank you very much. Can I be heard? Thank you very much, Professor Moderator. I think if we look at the current state of nursing and midwifery practice in Ghana, we can pick it from several perspectives. And I would like to pick it to the in-service. You could see there are deep-rooted issues that need to be addressed. And because of that, you can see the results of nurses who have come out of school and have been licensed to practice, and yet you can see these people have a gap when it comes to practice. When it comes to monitoring and evaluation, what I've seen with my nurse managers is they tell you every day they go round to go and assess services. So I go and assess services at various wards and units. And one question I always ask is, how do you go about doing that? You say you go there, you ask them, how are you faring, isn't it? And then they tell you, oh, we are fine. So when they tell you we are fine, then you assume that what? It's fine. But then the activity is called, to me, I say it's called what? Looking. So you go and look, and then you ask, how are you faring? We are fine. Or they tell you you have a problem. But the import of going to monitor and evaluate somebody is not that you are going straight to go and identify gaps, or you are going there to go and ask questions about what the problem is, but to see even if there are best practices, so that those practices can be something that are documented for future reference in practice. When it comes to research, it's an area we have not touched at all. Although if you look in the nursing fraternity, there are a lot who have done the first degree, there are a lot who have done master's degree, and now, I think for master's degree, they are now doing a sandwich program of master's degree. And then we can now see a lot of nurses also doing PhDs. But then it's like they come back. I don't know whether because we have been socialized from pre-service, that theory and practice don't mix. When you go and learn something and you come, you do not practice it. It is something you go and learn for your head, but not for your hand. So that is how I have viewed research as well. Thank you. I'll leave it to others.
Thanks so much. My dear next, do you have something to add to that?
Okay, so what I can say is even research has proved that Ghana, when it comes to nursing and midwifery, they have progressed. But still, we have gaps. And it's starting from nursing education is there. Then the clinical competency. Because here we are, Ghana now, we have nurses who are sitting in their various homes for 4 or 5 years. And the knowledge they acquire from the schools are all fading. Some are selling tomatoes, some are selling pepper, some are doing hairdressing. And when you recruit them and they come, they don't know anything. So the moment you do recruitment and then they go to the ward, you see it in the patient care. Patient will start, relatives will start reporting. There are a whole lot of issues on the ward. And this is challenging. And what is most painful is you take your time, you train them, they pick up, then they japa. Yes, so it comes back to zero. That is what is happening now. But you see, in all this, I think nurses and midwives, we should be able to acknowledge the challenges. And then we should discuss it with our teams. And then we take it up. And we have to say to ourselves that we are here to give out what? Safe care. So that the nursing excellence that we are talking about, we can get. There are challenges though, but we have to face it. So that is why we are saying that some of us should be seated at the decision-making tables so that we can talk about lack of resources. You go to some hospitals, you see they know, but what to work with is not there. And it is so sad. The environment, let's talk about the environment. It's not conducive and inviting to work in such environments. And I even sometimes ask myself, is it magic? Yes, it's like they are performing magic. This is a huge challenge. So the gap is there. And if we are not careful, we cannot navigate back. This is what I can say. Thank you very much.
Thanks so much. Okay, Amy, what factors do you think most contributed to the existing narrative about the quality of nurses?
Yeah, there are so many factors that are contributing to the narrative of nursing and midwifery in Ghana now. The first one that I can think of is training. And in addition to training, we are talking about regulation. So we can see that as for training, there has been an improvement in training. And we have strong regulations by NMC, Ministry of Health, and other bodies. However, the quality of care in the facilities are different. So, what are we doing? What is the issue with the training? If the training, we don't really do the right thing, it is not well structured. We will have the training, but we are not going to also see the result of the training. And the regulations, if they are not also enforced, we will not get it. In addition to that, we have conditions of service that is also contributing to our narrative. The number of staff that we have and the resources, as my other colleagues have already said it, they are also contributing to our narrative. If we have shortage of staff, and then we will not have it. But where we have staff and we have resources, the resources are not limited, we will see that productivity will increase. And also, we have to look at the perception of the public. It's also contributing to our narrative. How are they seeing our care? What is their experience? When they have negative experience, it really impacts negatively on our narrative in Ghana. However, if we are able to give them the care that they need, we give them the attention, we respect them, it will go a long way to improve on the care that we are giving. So these are the few factors that I can mention that they contribute to the narrative of nursing and midwifery practice this day in Ghana.
Thanks so much. I understand there's a fourth panelist, that's the nurse manager for OT region. Is she around? Can you please join us? Thanks so much. We are talking about quality of nursing and midwifery practice in Ghana. And the narrative we are talking about largely is negative. How do we change that narrative? How do we correct that narrative? That's all we are talking about this afternoon. Much of it, or some of it, to do with resources, some to do with training, and I say monitoring evaluation is not a fault-finding mission, but leveraging on strengths, leveraging on best practices that can improve services delivery is key and crucial. Thanks so much on that. And this morning we talked about leadership, which is what this conference is all about. Leadership, management, accountability. Madam, you're welcome. Sorry to put you on the spot. How can management accountability be strengthened to ensure that quality standards are consistently met across all levels of care? Madam Eva mentioned that there are inconsistencies. There are no standards in measuring some of the training we encounter in the clinical practice. How do you think that accountability can be strengthened to ensure that quality standards are consistently met across all levels?
Thank you very much.
From my perspective, I think there should be regular performance review at all levels, the administrative levels. And at the same time, I think there should be transparency in the way we build capacity. Sometimes, when we want to build the capacity of our staff, we are being selective, but we should look at how we do things. Those who are able to perform well, there should be a system for rewarding them, and it should be transparent. But when we don't do that, the staff have different ideas or perspectives about how we select our staff and reward them. So in my view, I think when we do that, it will help. Thank you.
Thanks so much. And then the next aspect I want to know is, unless Madam ever want to say something on that, in terms of leadership and accountability.
So I think for the service, there's been some trainings on leadership and accountability. In accountability, we've used the performance appraisal system. So you see people do the yearly appraisals. But then for the yearly appraisals, they are not done well. And they are not done well because people don't understand how to set objectives. So you see somebody at a level of a principal nursing officer, and the objective for the year is to, one of it is to organize meetings, just that, organize meetings. The next thing is to make sure that the attendance book has been, so you see, you look at objectives and you look at the person's rank, and you are wondering, how can you set such an objective at your level for a whole year? And then these appraisals come all the time for us to do interviews on them. So it tells you fundamentally, we need to look at how do we develop annual plans. So annual plans at a facility level, for instance, a ward in charge should have an annual plan. But an annual plan should always be based on some gaps and challenges and some situational issues within a particular ward. So if there's a specific nurse or midwife in a particular ward, and the ward is specific for maybe medical nursing or surgical nursing, the annual plan should look at the gaps that you want to correct during the annual planning. And the objectives you set there should feed into your appraisal plan. But it is not so. It is another thing altogether. And sometimes you see a DCNO or a CNO has sanctioned such an objective setting for a year. So I think we need to really go back to look at what are we talking about when we talk about performance management in nursing and midwifery. So performance is in reporting. If it is reporting, how do you report? How then do you also state within your annual work plan that you are going to do this activity? This is the report that will be produced. These are the indicators that will measure your outcomes. So there's a whole lot of discussions that have to come into setting indicators and achieving those indicators that will satisfy you for a particular year. Thank you.
Yes, I agree with you. I think we need to have some KPIs. If you are a senior nurse, principal nurse, or chief, and setting objectives, annual objectives, it should reflect what you do. It should reflect your position. So if you set an objective so low that a basic or level nursing officer should do at the end of the year, what are you doing as a manager? So we are talking about effective resource management as well. So clearly, if your objectives are not commensurate with your work and your duties, then that becomes a challenge. And again, I'm asking the question whether we do have job descriptions. You have the specific job description from nursing officer to senior nurse, running through all around. Then we should be able to be more accountable and set realistic objectives that we can actually be appraised on those things. But if we don't have these clear guidelines in terms of job description, then again, we are in that bit of a state of confusion. That's something we need to look at. Madam, anything to say on that? Amy?
Yes, I wanted to say that the performance management, it should be attached to, or it should be viewed as a way of development for the staff. so that we know that after achievement of these goals, the staff will get to a level that we know that at least the staff is growing into the profession. But if we are not seeing it that way and we see it just as a routine, something that we are doing, that is why what director said is happening. Because most of us, we wait when it's getting to interview. So we call, the person will bring the appraisal form, and some of us, unfortunately, we even ask them, what do you want me to write for you? And they tell you what they want you to write. Sometimes you can see excellent, 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 excellent. There's no even room for improvement on the forms. So we need to target to professional development to be able to achieve our aim. Thank you.
Thank you so much. In fact, it is not only within the practice. Even the university will have the same thing. Before you go for promotion, you need to have this kind of confidential report from your immediate supervisor that identify gaps, areas for improvement, whether in research, in teaching, and all that. So again, we need to be very realistic and have a system that can we trust. If you do take excellent, there's nobody who is excellent. But we need to be very realistic and say, oh, there's a room for improvement. We all make mistakes. There's nothing wrong with acknowledging your mistakes. And of course, like most of you committing drug error or doing wrong intervention in clinical practice, and you are not able to reflect on that and, oh, I've said, I have done A, B, C, D wrong. I think that's not the nursing we're talking about. We want people who are honest, who can be trusted, and be able to come out and say, oh, I have done so and so wrong. How do I get the support to do this? And the performance reviews and the in-service training, these are the gaps you pick. You are supposed to pick and catalog these gaps. So that if you need some kind of training, continuous professional training, then you bring them up. Oh, so and so have done this mistake, this intervention. It's maybe because they haven't had enough training. How can we support the individual to improve in that ground? And that's the honesty and trust we want to build, so that we can be fairly sure that a patient under our care, parents can be assured that you'll be giving the right care. And that will go a long way to change the narrative we're talking about. Madam Judith, all these we're talking about have policy implications. Do we think it is so because we don't have enough policy frameworks to guide us? Why are we struggling as a nation?
Okay, so we have enough policies in the systems. But you see, policies as they are being kept in drawers. They are not available to us. And when we have policies, I strongly believe that you need to take the staff through training on the policies. Some, they don't understand even what has been documented on that paper. So we need to train them on the policy, and we need to direct them or guide them what they will need to do to be able to conform with that policies. And then the policy too, we have to review the policy each and every now and then as new things are coming up. And then some of the policies too, they are not clear and they are not standard. So these are some of the things we are facing. And then also there should be transparent oversight over policies, so that everybody will have access to it, and everybody knows that in this policy it says this. So if the person goes against the policy, this is what, or the punishment or whatever should be given, or we have to do. So if we don't make things transparent, the policies will be there, we can't use them. We don't understand them, and we will not go by it. So that is why sometimes we encourage whistleblowers in the organization. It's good. They can tell you what is going on. And they will tell you that we read this policy and this is what is in that policy. So you take it up from there. So we need to meet and discuss the policies, so that we, the leaders, will get the understanding. And then when we get the staff, we'll make them aware of the policy that is existing, so that it can work for us. Thank you very much.
Okay, thank you. They say ignorance is not an excuse. Madam Eva, do you buy that idea? The policies are available, but sometimes they're either vague or not understood. And therefore, people possibly do not follow or apply them. But there are consequences, whether you are aware, you understand, or you do not. What do you say about that?
Okay, thank you very much. Yes, policies exist. But policy exists as intent. It can be a policy by intent. And the difference is you can also have policy by practice. So in the policy, there's an intent in the policy. But because, you see, policy formulation has to do with experts in a particular field coming together to develop a policy. Now, if you call the experts and you do not call all stakeholders within that policy frame, then it means you will develop a policy that is skewed to suit others but disenfranchise others. So if you have done it to suit others, those who have been disenfranchised, because they were not co-creating that policy, they can also decide that they are not going to use it. So then you will see that then the policy by intent cannot become the policy by practice. Now, when we look at policies in general, policies must go with an implementation guideline. Because a policy has been written in a brief as statements. Now, the implementation guideline picks the briefs as statements and then tries to express the definition of what the policy is saying into how it can be implemented. Like you said, that when it comes to human resource, there are job descriptions. If you look at the job descriptions for the various cadres, you can have 25 items, some may have 28 items. But those 25 items, if you read one, and the director sitting here, one of your job description will be ensure the provision of quality nursing and midwifery services in where? Your facility. What is the meaning of that? It's a very broad statement. What goes into it are nitty-gritties. So I always say that the job descriptions are not explicit enough. These job descriptions must be picked by nurse managers and dissected so that people understand. If they say you should ensure quality in nursing services or maybe in surgical or ENT nursing services, what does it mean? So that becomes an implementation guide for you to see that when you are practicing as a staff nurse or as a PNO in surgery, the difference is A, B, or C. But all too often, you can find a staff nurse work for 1 year and their knowledge and practice is almost equal to an SNO, which should never be. The SNO's practice should be higher than what a staff nurse is doing. But too often, before you realize, they have equaled. And then the staff nurse will start challenging the SNO. What you are doing, I don't think is correct. What you do is not correct. And because we don't have the guidelines to guide practice, then standards of practice become somebody's perception of what the good should be, but not necessarily what it should be. This conversation came up when I think the members of the healthcare, the service started discussing the specialist nurse. Because, and that's why I said the issue about the nurse specialist, we need to have another day to discuss it. Because there's a lot to talk about. You know, they came into the system as a shocker to doctors and to nurses alike. Because their placement was not carefully integrated into the health system. And that is where policy issues come in. Now, if you are placing somebody higher than a nurse manager, and you do not create a system within the facility that will absorb this person, and everybody understands what that person's role will be, it is going to be a catastrophe. So nurses were complaining and doctors were complaining. And when doctors were complaining, are they also going to be prescribers? What are they coming to do? They say they want consulting rooms. Because policy by intent was not the same as what? Policy by practice. So we need to have clear implementation guides on what we need to do. Now, when you come to the health service, there must be a nursing policy. If you look at human resource, for instance, the numbers, we don't have a policy on staffing ratios. So if you come to an emergency, is it supposed to be 1-to-1, or is it supposed to be 1-to-2, or 1-to-3? Nobody knows. Currently, we want to collect that data so that we can say that when we came to Ridge Hospital, the ratio was 1-to-3. And because it was 1-to-3, every day, 10 patients were what? Dying. And a lot that we thought we could save, we were missing them because you have been able to collect data that is telling you that your staffing ratio is wrong. But up to today, we don't have a nursing policy that the government has sanctioned to say, when it comes to administration and management, these are the governance structures. This is how a nurse manager is supposed to be placed in the health system. When it comes to practice, these are the staffing ratios. These are the limits of nursing practice in the facility. Up to today, we don't know. Are nurses supposed to enter veins? We don't know. In teaching hospitals, they don't enter veins. In district hospitals, they enter veins. Elsewhere, there's a whole lot. If you look at a midwife, teaching hospitals, their work, they cannot do what a district midwife will do. So there's a whole lot of differences and a whole lot of nuances that we need to seriously address when it comes to policy on nursing and midwifery. Thank you.
Thanks so much. So like we mentioned earlier on the day, the policy, we being part of the policies, formulation and implementation, that's where we are still lacking. And how do we get stakeholders to address these issues? What do you think is the way forward? We have numerous policies, but they are not tailored to our needs. They are not things we can consume as they are now. What happens in Ghana is, any policy that comes out, nobody thinks about tomorrow. You can even think about the training. They mentioned today about specialty training again. Nobody thinks about what is going to happen to them tomorrow. After we produce the specialist nurses, the question I ask is, do we have all the competencies across the country where they can fit? How many of them are we going to train? Are we turning all general nurses into specialist nurses in the next 10 to 5 years? I have no idea. But as I mentioned, it's always good to see cadres of nursing profession being created, and the human being is an actualizing being. Tomorrow they want to progress. Tomorrow they want to develop. What do you do about that? So we need to be having a bigger stakeholder engagement in expressing these concerns, and of course, getting some of these policies tailored to our needs, how we want them to be. Thank you on that. We talked so much about CPD, workforce development and maintenance. I'll come to you, Madam Judith. Continued professional development and mentorship programs. How do you think we can leverage this to improve practice? Leverage continued professional development to improve practice. CPDs.
Okay, so continuous professional development is something that every health worker should participate fully in, because each and every now and then new things are coming up. And if you have a skill and you don't work on that skill, whatever you know is one way or the other will fade. So you need to improve on it. New things are coming up, and that is even one of the reasons why we are here today. This conference, we are learning a lot. So if you don't avail yourself to CPDs, then you will be lacking behind. When it comes to the second one is CPDs and mentorship. Yeah, mentorship has now become part of the system, whether you like it or not. And I will use this opportunity to tell every facility to come out with a full program on mentorship. You have to develop a curricula. So in my facility, I have a curriculum on mentorship. And we have mentorship training every year. We select mentees, we identify staff that we know they can teach. And then they are the mentees. And then we have mentors we have trained. So they also go training. So as some are fading away, new ones are coming up. And then we train them, and then after the training, we give them certificates, which is being recognized. So I will encourage, and it's helping a lot. It's really helping, because right now, the facility is expanding. And we have a particular standard of care that we are looking at. So if these mentors and mentees are not on the ward, we can't do anything. as I sit here, I can't see everything on the ward, and it's helping. So even I have a dashboard, and I have mentors on the board, and they tell me what they are doing, I see. So I see the number of patients on the ward, and I see the number of nurses, because I'm particular about the nurse-patient ratio. So before they will call me, I have seen it, and I put in measure. I deploy staff from less busy areas to the more busy areas, and that's what I do, and it's helping. So mentorship program and CPD, we really have to embrace it and work on it fully. Thank you very much.
Brilliant. Thanks so much. I think UGMC did something very wonderful that we all need to emulate. Mentorship, we cannot run away from that fact. All of us, every nurse potentially is a mentor. And you can hear from her. They give them training, they give them certificates. Yes, we can find various ways of motivating them and appreciating what they do. And I know the money issue will come in here. But you agree with me that with the increasing number of students, you will continue to have to develop and train people to be mentors. And of course, depending on the experience of the nurses of ward, depends on the level of the student, we can encourage that so that the numbers can go up. The money we pay are not sustainable. Madam Eva, I think we need to be thinking about this. How much can you give to preceptors to motivate them to do this? It's a job. And as a nurse, your role as a teacher, as a mentor, we cannot run away from that fact. Unless we come up with something concrete that the ministry can buy into that. How they want to support you, whether you are senior nurse officer, whether you get some allowances or whatever it is. There's something must be done. I honestly do not believe that taking some people in the ward, train them as mentors who are not adequate anyway, and giving them money is sustainable. How much is it? So again, we need to think about innovative ways. We can come out with mentors that can support the student needs. Either than that, we're going nowhere. It's a very interesting area we need to discuss further. Thanks so much. Madam, Oti Oyi, I didn't get your name. What do you think? What happened at your area regarding mentorship? What's your experience?
Thank you so much. Please, at our level, we have mentors in some of the facilities. So they assign the facility nurse managers, assign them to the nurses who are less experienced so that they can equally learn from them. The same way, I think with the CPDs at the facility level, we should look at the gaps in performance before we can organize a CPD. If we don't know the gaps, you may organize a CPD that doesn't conform to what you want. So in our place, some of us are doing that. They identify the gaps and then they conduct the CPDs for the staff. Thank you.
Okay, thanks so much on that. I have what can managers do to motivate and retain skilled nurses and midwives in underserved or high-stress settings? Manaebi, underserved and high-stress settings. How can managers like you motivate and retain the skilled staff so that they don't run away to UK or America? What strategy do you think we can deploy?
Thank you very much. I believe, I think that first of all, managers should create a supportive and appreciative work environment for the staff, recognizing efforts, providing opportunity for growth, and involving staff in decision making. This will go a long way to retain them. When they feel part of decision making, when they know that you appreciate them, the little that they do, they are recognized. I always say that nurses, we don't want much. It's the little that you give to a nurse, she's appreciative. You want, okay. Hello. Hello. No, what I just want to say is that when a nurse is working and you as a manager, you show appreciation, the nurse is happy. That is all that I want to say. I'm not talking about our monies and all that. So I'm saying that let's recognize them. It means that we are creating that supportive environment and appreciative environment. That is what I mean. And also, let's keep on giving feedback. When we give feedback, they will know whether what is happening is good or not, their performance is good or not, so that they will also, it will help in retaining them. Thank you.
Thanks so much. She's not talking about monetary motivation. We all know it's very important. But Prof. Chair said, don't be so chinchina as managers. Open up, improve our relationship, encourage them, motivate them. Money is not everything, you know. If money is everything, and I'm not sure if we're standing in Ghana, but we can show the appreciation, acknowledge, give constructive feedback, give supportive, create a novel environment, and I'm sure they will be able to stay. And when they're due for study leave and all that, you can find a way of managing that so that you don't retain them unnecessarily. Let's find a way of dealing with that so that people can feel valued and appreciated. Thanks so much. I think I need to give room for some questions to the floor. If there's any question you want to ask the panelists, I in particular want to ask one or two questions about professionalism again and ethics. Any question to the panelists before I throw my question? We talked about leadership, management, accountability, policy system strengthening, workforce development, and ethics. Yes, let me come to you first, please. Yeah, go ahead with your question. Please introduce yourself once again so that we remember you.
Hello. Hi. Thank you, Prof. Moderator, for the opportunity.
I can't hear you.
Once again, my name is Lawrence Barumi.
We can't hear.
My name is Lawrence Barumi. You cannot hear.
We can hear you. Go.
Yeah, go ahead.
Okay. So, Lawrence Barumi, Laura Municipal Hospital, nurse manager. Prof. Moderator, I want to make a special appeal to this conference to specifically look at the issue of nursing policy in the area of practice, because there exist so many gaps as far as practice of nurses and midwives are concerned at the level of practice. As I speak as nurse manager, maybe my colleagues here will disagree with me. Because of policy issues, I am not given an appointment as nurse manager. Every other core manager in the hospital has an appointment as a core manager. So sometimes it's like it's on favor being done you to be part of core management. If you go to the regional directorate, there is a split in the structure of nursing leadership. For instance, the chief nursing officer is placed under the deputy director of clinical care. Now, what that means is that the system has automatically cut away the preventive nurses. So the question is, are they answerable to the chief nursing officer? Because the public health nurses, community health nurses, they are not under the clinical care division. So these gaps, to me, are calling for a policy that can reunite and put everything together, especially that director mentioned that we are still developing some standards for the other cadre like midwifery and mental health nurses, so that we can push from here to have a policy that back our service. Thank you very much.
Thanks so much. Let's take the other question or comment.
Thank you very much, Prof. My issue is that one of the panelists did mention that we have almost all the policies, but implementation is a problem. But I disagree. There are still a lot of policies, the bigger ones, that we are not looking at. And one of them is what my brother is talking about. In fact, if you look at the health sector, nurses constitute more than 75%, about 80% of the workforce. We generate the resources. We are the people who generate the resources. But when it comes to spending, we are neglected. A policy must be formulated, implemented. In fact, before this conference ends. The nurse manager must be a part of approving every expenditure in the hospital. Without his signature and the medical soup, no money can be spent. This is the only way. When we were talking about people go for upgradement, advancement in training, and they come and there's no change in implementation of what they have learned. What is the cause of it? People are staff nurses or PNOs, they go and do a degree and come, and you don't see change in whatever they have gone to learn. People have gone to do specialize in nursing. They come and you don't see any change. Why? It's because when they go and acquire the new skills and come, they need certain tools, environment to work with. The nurse manager doesn't have the resources to provide it. Most of the administrators and the accountants, they have different priorities. The nurse manager cannot have the resources to be able to do it. You are relegated. You go and you are begging. Look, if you do the same thing all the time and you want different results, forget it. You are lying. Please, let's reorientate ourselves. We must enforce such a policy.
Thank you.
Without the signature of the nurse manager and the medical soup, no expenditure. We cannot be generating and we cannot spend. It is not possible. Okay. We must generate and we must spend. Okay. The field workforce cannot be deciding our fates. Please, let's look at it seriously. Otherwise, all what we are discussing, it involves funds, it involves resources. We cannot do much by begging all the time. We can't do it. Please, let's look at it. Thank you very much.
Thanks so much.
Thank you.
Okay, let's add yours before the panel can react. Yes, go on.
Ophelia from Western North. I want to suggest a few motivations to add up to Madame Eme's motivation to we the nurses that want to stay in the country and then give back to society. Mine is on promotion. In fact, whether you have been to school to upgrade yourself or durational promotion, if you go for the interview, as and when the letter will come, it will be due for another year group promotion. And even if the letter comes for your promotion, for it to be reflected in your salary, it will take another year. And then the arrest too will not be paid. But if you are fortunate and you are put in that level or that grade that you have attained,
then you'll be happy and then you stay. But if you don't know anybody to work for you, the rest will not come. So as in the form of motivation for we that are staying back to give back to society, they should look at it for us. When you are due for promotion, if the interview is conducted, they should immediately promote us and then pay us so that they will not be keeping our few coins that we have been taking. Thank you.
Thanks so much, my dear panelists. We are back again. Policy and practice gaps. Okay, let's add yours quickly and then panelists can respond to them. Go on, please.
My name is Sarah Gani from Greater Accra. I heard either the Director of Nursing or Prof said that specialty is the way to go. Fine, we agree with that. But let's also not forget that the ones that we have even trained already is creating a problem for us. When the Director of Nursing projected her staffing numbers, we saw ENs leading the charts. Their bar was very tall. These specialist nurses, you see senior staff nurses and NOs already rushing to go and do their specialties. Because of the incentives it comes with, they know that as soon as they finish where they are placed, it's even higher than. So now everybody is rushing to that. Unfortunately, when they come back, they don't want to nurse the cases on the ward. You have DKA, hypertensive with strokes, and they don't want to nurse. And we are relying on the ENs to do that. Unfortunately, they are the larger numbers now. So you go to a ward, and on a night shift, you have two enrolled nurses on a shift, which doesn't meet the standard. And some of them too, because they have not been in the practice for long, senior staff nurse, going to do the specialty program, she come back, and already she feels like she is big like that. But on the clinical side, the enrolled nurse may even know more than she knows. But on shift, she's supposed to be the senior person on duty. And she will not be humble enough to come down to learn from the enrolled nurses. Because the enrolled nurses, some have worked 7 years, 8 years, 10 years, and they have experience when it comes to nursing those cases. So as much as we are trying to look at training more specialties, we should be mindful of the gap is creating. Who are those going to cater for the general cases on the ward? Otherwise, it will become a burden that will come back and then be looking at us. Thank you.
Thanks so much, my dear panelists. We are back to the nursing policy practice gaps issue. I would like Madam Eva to attack this first. The first one to do with the organogram and the various nurses you have, how they are placed on the organogram and the gaps that exist there. How can we address this? And the second one again is about policy implementation. The policies are there, but poorly implemented. People are generating, they are not having a say. People are producing, they are not having a say. They are the biggest workforce in every health setting. Why are their voices? Why are they not getting involved in all these things? What do you say about that?
Let me see. Thank you very much, Prof. I think next manager for Laura Hospital has opened the Pandora box. He was supported by his brother there. Can I stand?
Oh, why? Feel free.
This thing, you can't say it sitting down. So Act 525, when was it created? Act 525. When? 1996. Okay. So in 1996, you saw our directors out there. You saw pictures of our past directors there. In 1996, there was a split of the Ministry of Health from what? The Ghana Health Service. And what happened? There was an act of parliament that created divisions, directorates, and organogram structures.
Do you know that act eliminated leadership for nurses and midwives? You know, I've told you. That act. So you see, we were sleeping. So everything that has happened to us, it was because what? We were sleeping. It eliminated all nursing leadership positions. Even at the headquarters, the director nursing is not in the act. You come to the regional level, we are not in the act. District, we are not in the act. What exists is a facility level where you have a head of what? Nursing. That's all. So strategic leadership in nursing and midwifery is what? We are absent. That's the first thing. Number 2, we used to have the regional DDNS, you remember? So the regional DDNS were in charge of what? Nursing and midwifery at the regional level. And a proposal came to elevate them to what? Chief positions with extra salary and a beautiful name. But that proposal, and I keep telling my people, when you see writing in black, assume it is red. There is always something behind it. So make sure that you have eliminated all the colors that are associated with black. So you are seeing it as black. Meanwhile, it is blue or it's red. So when they created a CNMO position, that CNMO position was immediately fitted under clinical care. And that is what started the confusion at the regional level, where the CNMO is under what? Clinical care. And then regional public health nurse is under what? Public health. But then there's a recognition that there is a gap. When it comes to nursing services, it's not the regional public health nurse who will go and sit at management meetings to talk, isn't it? It's a CNMO. Okay. So now, I think we should start the public health conversation, isn't it? It's a next on agenda. Should I stop it and start? I should continue. We should finish this. Then we talk about public health nursing. Okay. Public health is today. So you see, so we have a regional public health nurse and a CNMO. Now when you look at public health at the regional level, it came with what? A lot of what? Resources. And coming with a lot of resources and a regional public health nurse being under a DDPH, with a DDCC being very poor, and a CNMO being under him or her, then we started having what? Split. Because the regional public health nurse things are what? She has resources and everything. If she likes, she will collaborate with CNO. If she doesn't like, she will not collaborate with CNMO. But you see, the division between the two has caused the weakness of nursing and midwifery in the Ghana Health Service to today. So now, before we realize, we started seeing health promotion coming up. Now, health promotion coming up, they are like, we are not public health nurses. So now, health promotion is standing as a division with powers and went to grab their power from public health nurses. Now you have nutrition going to grab, and now we have our public health nurses looking like what? Skeletons. So you are a skeleton, you are looking like a skeleton, although it looks as if there are resources coming to you, but at the same time within the regional level, they look for people who are coordinator for maternal health, coordinator for what? This, coordinator for that, isn't it? Regional public health nurse, is it not true? Thank you. Coordinator for this. So those coordinators will now come and teach you, the nurse, what you should do. So where are we going? You see, until we have an integration of public health and clinical care, which can be done at the nursing level, because we are the only cadre that can bridge the two together. Because maternal and child health is being run by public health, and the CNMO, unless your regional director likes you, and then says that go and do something on maternal and child health. But then what are we creating in the health system? A lot of confusion. And what are we creating? We have nurses and midwives who are also what? Confused. Because they can see leadership is what? Confused. And so when you come and you are trying to, require a lot of things from them, they are like, is this nurse manager serious at all? Can't you see the troubles that are going on? They can't appreciate the difficulties you have within where you are. So say, you have been eliminated from the acts. So for us to correct this, it means that we also have to what? Go and advocate and interrogate the act to place us there. But you see, when you are going to interrogate the act, although you are in big numbers, I'm the only one at the headquarters, isn't it? Like this. And then you have a lot. So if your voice is not loud, will they listen to you? So in 2020, we developed the restructuring of nursing and midwifery, the organogram, especially. It went to the Ghana Health Service Council. It took how many years, Antiama? 5 years? 5 years. And then the council decided that, okay, so for the regional CNMO, we are removing them from under the clinical care department so that they will stand within the regional health directorate. But if they stand, in what way can we leverage on having all the 4 areas of nursing and midwifery together? Mental health, public health, midwifery, nursing. These are the bedrock areas of the health service. If we don't come together and be under one CNMO to have a powerful voice, we are going nowhere. And that is where we have to work towards. Thank you.
Thanks so much. So we need to engage the actors, and we need to start talking about the policy changes. It doesn't happen overnight, but it's all about togetherness. You know, anything she can change, but all of us, maybe before you leave here in the next couple of days, we need to have a clear roadmap. How do we need and how do we go to get some of these injustices corrected? How can we fix, how can we correct some of these things? That's what we need to be thinking about going forward. The other bit is to do with promotion. I already mentioned that we are not talking about motivation in terms of money, but also in terms of promotion, upgradement. Okay? So if people are due to go or to have promotion either after school and need to be upgraded, we as managers, every human being, promotion is a right. We only need to be sure that the person is delivering. And whilst they are delivering, when they are due for promotion or agreement, it should not be an issue. So that alone can serve as motivation. Time is far running. The other lady mentioned of the specialties. And as we mentioned earlier on, they are talking about specialty training for nurses, which again linked with the policy we are talking about. How much involved were we in this policy direction they want to do? And as I mentioned earlier, if they are going to train endocrinologists, nephrology, all sort of specialties, we know when the system becomes saturated, we are the same people who will feel a bit redundant. We are the same people who will dictate where we want to work. And again, like Madam mentioned, most of the policies, you go to the implementation of practice site, there are no resources, there's nothing to actually support your learning. That even happens to the medical doctors as well. So we don't think through the policies we want to implement. We roll them out 2, 3, 5 years time, and the system is choked, and we're beginning to create problems. But with all that, going forward, I wanted to look at what 3 key actions should be prioritized on managers within the next year to shift quality narrative. What 3 actions do you think as managers, all of you here, you will prioritize that can change the narrative the public perception about nurses, the quality of nurses we are trained. What do you think we are going to prioritize going forward, let's say in the next 2 years? Should I come to the panel before I come to the floor? Or it's open, actually. Priority areas. I will go back to our facilities. What are the 3 key actions you will prioritize as a manager in an attempt to change the narrative regarding the quality of nurses and midwives we have in Ghana? What do you think we need to be doing? Yes? Is your hand up? Yes, please come forward. We need to leave this conference with a very determined and a focused agenda for action. With policy engagement, we need to get it right. Where do we start and where do we go? Okay, go on, my dear.
Thank you for the opportunity. Unfortunately, it's not the facility level, but I think it has to do with education. We as nurses, I think when I was growing up, in the year 1983, enrolled nursing stopped. Only for us, after some years, I don't know for which forces it was, enrolled nursing resurfaced. And up till now, I think that is our problem. If you go to the Ghana Education Service, even the preschool teacher is enrolled and comes out as a degree person. So what is the issue? For the image to be uplifted, then I think nursing should start from the degree level. That will be number 1. Because you train an enrolled nurse who comes up and always thinks she's inferior. For us professional nurses, we look down upon them. But they are the majority. We want to satisfy government. We want to improve the numbers. Is it quality we want or the numbers we want? So please, council, let's look at this. Thank you.
Thank you very much. We need to make sure that at least we start off from the degree, which already is happening actually. Most of the training colleges, as far as I'm aware, are beginning to roll out degree program, isn't it? The question remains, we still have the NAP being trained. I'll come back to that. Yes, go on.
My name is Josephine Darling, and
we can't hear, please.
My name is Josephine Darling, and I'm a member of GNA UK. And I would say that starting my career from Konfanochi as a midwife before ending up in the UK, I can only talk now and ask questions about what's happening in Ghana now. Because it seems to me like we have mixed American system, UK system, box it together, and we don't know where we are. So the best thing would be communication. Communication. In the UK, before they started degree, it was the registered nurses, SRNs, who were training the degree nurses. And so gradually, pensions, it is out. So now, it is degree for everybody from secondary school, and then you are healthcare assistant. If you want to change over, you get the necessary skill and qualification and go and do your degree nursing. Then we come to this specialist nursing thing. In every specialist, we qualify as nurses, we do our rotation, then we make our mind we want to be here. Or you are a student doing a rotation, oh, I would like to come back here. So that this business of where do we want to be doesn't become a fight or looking down on somebody or looking up on somebody. You want to be a NICU nurse, you went to the university, start with your practicals from where you are, go and do your NICU So in every specialty, all of them are specialist nurses. The rest are students. Or you were qualified nurse, you came, and gradually you went and did your course and came back. So the system here, I think we have created confusion for ourselves. As Madam said, that's what I will say. We were following the straightforward British system. Let's carry on. What made us use American, British, Canadian box together? This is what and as nurses, I think we should be bold and strong and be able to face them in Parliament. This January, I heard someone, we can't go to Parliament. Who said we cannot take our unified unity decision to them there? Because we will be in majority, so we have a voice that this is what will work better. We want better training, better equipment, everything on the world. I want to nebulize the patient and turn around and I'll pick it up. I want to do this and I'm starting. Not a where is it, where is it? No. So we are creating the problem for ourselves. Thank you.
Thank you very much. Okay, the last person, let's hear from you.
Yeah. My name is Faustina Ejekun, Mansha District Hospital. I just want to buttress the points my colleague made at the other side concerning the enrolled nurses. In fact, they are the majority, as she mentioned. And sometimes it affects our roster so much because now they all want to upgrade themselves. And then if on the roster at the ward, if you have maybe 12 staff, you see that about half of them, they are all going to school, doing weekends classes, and at a point when they are writing exams, they will not come to work. And then they will come to you, we need staff. Meanwhile, I don't recruit staff. So all that I want to say is that I stand to be corrected. I know it is very difficult. At a point, there was a release of letter that training should be stopped. Within 24 hours, there was another letter saying that it has been cancelled. In fact, there's a lot of schools right now, nursing schools. Sometimes when you receive a letter that they are coming for clinicals, at times that's name I've never even heard it before. I have to call somebody at NMC to find out for me whether that school is accredited or not. So in fact, I'm just pleading if authorities can do something about this enrolled nursing training so that you all continue with the degree. Thank you very much.
Thank you very much.
Talking about quality.
My dear panelists, unfortunately, Madam Eva, I come to you again. The training, enrolled nurses, degree nurses, what is it? Where do we go from here? What is the way forward? Because the enrolled nurses are the majority. We know the policies behind it. And we know the quality and the training that come with it. What is the way forward? What can we do about this cadre of nurses we are producing? Thank you.
I should say.
Yes.
Thank you very much, Prof. So fortunately for us as nurses and midwives, I think government is looking at the controlled migration of nurses and midwives. So now we would rather be exporting the nurses to the various countries. But the request that came, oh please can I finish? Allow. The moment you start talking, then I get confused, I can't speak again. And all the countries that came, in their countries, the nursing levels starts from degree. So when they came and we were diploma, they're like, no, they don't want diploma nurses because for their entry point is a degree program. So this drew attention to the fact that now we need to look at upgrading our institutions to degree awarding institutions. So now the conversations has come. HTI has now worked out the degree program for nurses and midwives, so that now we want to tailor it down to the barest minimum. So now, if you were taking, for instance, 500, the diploma nurses, with this year you will take 200, next year you take 100, and then 50, and then you phase it out. So now there's going to be a phase out for the NACNAP and then the diploma programs, so that we look more at the degree programs. So that is what is on table now. I was privileged to be part of the meetings, and so I know that is where we are moving towards. Thank you.
Thanks so much. So eventually it's going to be phased out. As to whether we are going to stand by that or stick by those words, I am not very much sure. But again, we advocate that policies that are getting rolled out, let's get involved. Let's find a strategy. Let's influence those policy decisions because they roll out. And as I mentioned, this specialty training we are going to mention, we need to start thinking, how is it going to be like? Are they going to be the ordinary general train? Will they demand for salary increment? Will they recognize in the band or the scale within the Ministry of Health? Are we going to have facilities to support whatever learning we're going to give them? These are the issues you as nurse managers and leaders is within your power. Let's come up with innovative ways of engaging policymakers that can address things that are pertinent to the nursing profession. I don't think time is fast spent, whether we have any space for any more questions. Do you have a question? Okay, the final two. I think time is fast spent. Let's take the final two questions and then we can keep engaging. This is the first and the maiden conference, and you can imagine how many issues are being discussed. So we're only hoping that we have more of this to be able to bring out some of the concern we have. Yes, go on, please.
Thank you very much, Director, Prof. Our Director for Nursing, fortunately for you, have the numbers. You have the numbers. In fact, we are behind you. We can follow you to Parliament for all the policies to be changed. Prof asked for 3 policies that we should discuss. For me, 1, all regional CNOs should be made deputy directors answerable to you direct. We should demand it now. Like I said earlier, all the nurse managers should be made signatory to the accounts that they generate. We must march to Parliament and demand it now. In fact, you didn't talk about it. It's very passionate to us. Otherwise, our existence is useless. You see, somebody talk about the enrolled nurses and their numbers. Why the training surface? They saw that our numbers in healthcare delivery was less. The registered nurses in the system at that time were not many. There were pressure on them. The policymakers, the politicians saw that they could use that place to create jobs because they didn't know how to create jobs. And that was why they just decided to train them. In fact, it started with what they were calling Zoom nurses. I remember very well in Kufuor time, they were just recruited and given 6 months training and called Zoom nurses. Then from there, they decided to regularize it and start training them. So that was where the policy started. So we can ask that, like the director has said, we will go by it. The phase-out system should come, and then there will be upgradement. Thank you very much.
Thanks so much. The very final one, gentlemen, yes.
I think it's okay. All right. Mine is not a question. I just want to contribute to the discussion and what we should do to improve nursing profession in Ghana. I think we have a very serious problem so far as nursing training is concerned in Ghana. Why? If we all can attest to the fact, we realize that the history of nursing, before you become a tutor of nursing training college, you should be well baked so that you can impact knowledge into somebody to become a nurse. But what do we see today? Somebody who has never practiced nursing before is a tutor of nursing training in Ghana, and they are baking the student halfway. So you could see that the products that are coming into the system, in fact, we cannot guarantee this drop of students that are coming into the system. Somebody stayed in the house, an enrolled nurse. The person was trained as an enrolled nurse. And then because they are not posting them, so the person have the opportunity to go and do a degree in nursing. Before you know, that person has never even practiced. The person is a tutor of a nursing training. And then when they come into the system, because I know somebody who is a big man somewhere, the protocol, insubordination is becoming something that is affecting the practice of nursing in Ghana. If we are not careful, because I know Director Eva, I want to go to nursing. I don't have the interest because that is the only way I can use to get job. I come to Director Eva, please help my daughter to become a nurse. Even though that my daughter is not having the interest of nursing, I have the protocol, so kindly, admit my daughter. The person come into the system, and that person is misbehaving. That is why you could see nursing even at work, taking live pictures of their patient on the hospital bed. I don't want to go further. Thank you.
Thanks so much, my brother. I can see the passion behind it, and I can identify myself with you. It is a worrying trend. Before I go back for my closing remark from the panelists, that is very much observed. Most of you, as you may be aware, University of Cape Coast, we used to have BEds in education. Many nurses after NTC college did that program, and most of them wanted to go and teach at the NTCs. And it's very much the same he's talking about, that the content is not there. We go and do education, that's the pedagogy, but you need to have the knowledge and the experience before you go out there to teach. And I can assure you that's getting changed. If we are going to roll out all nursing training college to degree awarding, GTEC is going to be watching that. And if you don't have a first degree in nursing, there's no way you can teach. And before you teach a first degree, bachelor's degree, you need to have a master's degree in the relevant field. So that I can assure you that it's changing very much. Even if you have a degree, a master's degree, and you don't have a BSc in nursing, and come to UCC, as far as I'm concerned, I am not going to tell you. You must first of all have a basic first degree, relevant masters to be able to teach a first degree student. And you must have a PhD to be able to teach a master's student. So that is a huge concern out there in the NTCs. And I agree with you 100%. But I can only hope that GTEC is going to address all that. And of course, in the next 10 years, we hope to see big changes. Madam Director, your battalion are ready to march with you to Parliament to make sure that the right policies that are placed relevant for nurses are done. They are ready to march with you to look at the organogram and see how best nurses can be placed. They want to advocate that when they generate, they want to be proud of any signature and the checks that they generate. So I'll come back to you for closing remarks. I'll start with you, my dear from the Oti region. Anything to add into the discussion, please?
Mine is an advice to us. We should know that quality care is not optional, but it's our professional and moral duty. That is it. Thank you.
Quality care is not optional, professional, and a moral obligation. All of you need to understand that. Yes, a big lady herself, what do you have for us? We are ready to march with you.
Thank you very much, Prof. I just wanted to add something to what the last but one speaker said. He talked about the history of the retraining of enrolled nurses and bringing them into practice. But one thing I want to reiterate is, when we retrain the enrolled nurses, we as nurses taught policymakers that it was possible for enrolled nurses to replace professional nurses. Because then we started putting enrolled nurses as in charges of wards. Some of them are even managers of emergency units. So then if you can demonstrate that enrolled nurse can manage an emergency, then why would they spend more money to recruit professional nurses and pay them more when the same job can be done by an enrolled nurse at a cheaper rate? So for us, I always say, let's sit back and reflect on our contribution to how the service of nursing and midwifery is looking today. Because those days, if we said there was no nurse to run a shift, and so because of that, we're going to close a ward and say it's only an enrolled nurse. That enrolled nurse cannot manage the shift. What would have happened was that government would have gotten to hear about it and made plans to get more professional nurses. But then we showed that it was possible to use an enrolled nurse, and that is why it is the same today. And to today, have any of you managers here written anything to demonstrate that putting an enrolled nurse as an in charge of a ward has caused A, B, and C on the wards before? Have you? No. So it's only in oral talk. We can't see it in documentation. That enrolled nurses working has caused any problem in their health facility. So who is going to believe you? Nobody. Unless you demonstrate that their presence or their taking up of positions in clinical wards leads to the detriment of healthcare in our facilities. Thank you.
Right. So the challenge is back to you. Document those who are training them. Let's look at the training. Are they getting what they need? Are we sending consent a report to suggest that the training is not adequate? Those who are in your ward working, that are making them in charges. Risk assessment. Do you forward any concerns regarding their practice? If you do, let's be sure we have documentation and forward them and make our case. It's all about evidence. If we don't document, we don't have any evidence. We cannot make a strong case. But let us look at the training. I myself have my worries, which I will engage NMC. There's nothing wrong with having entry levels for people coming to nursing. And of course, if you are having a first degree and you decide you want to be a nurse, I don't think there's a problem being that. I kind of disagree with NMC having a year and expect that you go back to bring what's the result to do this. If I have a degree in chemistry, I decide that, no, I don't want to be a chemist, I want to be a nurse. That should not be a problem. I have an informed decision that this is the call, this is what I want to be. I see that actually more informed than somebody coming with WASI, who will say it's probably call or no call to the nursing profession. If that was the case, I wouldn't have the opportunity to be a nurse in the UK, which I think that we need to be looking at that. But what matters most is the quality we put into that. And those working, are they actually competent and working well? If they are not, let's begin to document, let's begin to have evidence that we can use that to report and, of course, address some of these concerns. Next, my dear, we are still on it. Your closing remarks on the various items we touched on. Anything burning in your heart?
Okay, all I want to say is if we want to shift the narrative around quality care, let us all lead boldly. Let us act tactfully. And then also, we model excellence. Thank you very much.
Thanks so much. Finally, Madam Mary.
And to add to that, I would like to say that quality care is our collective responsibility. Let us not see ourselves just as caregivers, but let's see ourselves as change agents who set the standard for excellence. Thank you.
Thanks so much. And on my side, I agree absolutely that the problems are created by us. Like my colleague from the UK, I myself was trained in the UK, but I happened to be in Ghana for the past 10 years. And I do agree that if we want to make any difference as far as nursing education is concerned, there can't be anybody more important than you. The clinical environment, the nurse leaders and managers. And I challenge you, let's change the narrative. And that narrative begins with us. There's nothing absolutely wrong if we step our authority for the profession and ensure that people do the right thing. NMC have a very strong collective role to play. But that's for another discussion. And on that note, I'll thank my powerful panelists for the very beautiful contribution, and all of you, and we'll bring the discussion already served to a close. Thanks so much for the attention. Thank you. Yes, I think we have done enough for the day.
We can do it once again for our panelists. By way of information, we are saying that dinner is ready. From here, we all march to the cafeteria to yes. Please, dinner is ready. So you kindly pass through the cafeteria, then you pick up your food. And for tomorrow, we are expected to be in the